If you work in the emergency department, this is where the magic happens. And usually when I say magic, I mean magic, because we have to pull some serious tricks out of our hat when it comes to dealing with 5150s, medical legals, and all of the rainbow of fruit flavors that happen to come into the ER that we have to juggle along with our other patient care issues and duties that we do. ERs tend to bottleneck. This is the time that this happens. We get patients in that have special needs. They're there for a medical hold or something else, and we're going to be holding them for an extended period of time. We've got to assess them. We've got to document all of the checklists of things that we are required to do. In addition to that, there are calls that have to be made. There are teams that have to come in for additional assessments. And usually in the end, that time could be a matter of hours to days. And yeah, I've been in the ER where a patient has been held for days, so long that their 5150 expired 3 days later. I came back on day 4 of my shift and the patient was still there and another hold had to be written. There are health facilities that just don't have the bed space. And as time has gone on, more and more facilities have closed. And this is just tragic, but it's true. And when you have a patient who has special needs, whether it be disabilities or an age related, like they're a child or they're a senior, there are some facilities that are not licensed to take certain patients. And that puts the burden back into the emergency department, and it means that you're going to hold them for a lot longer should space not be available. In today's day and age, mental health facilities are closing due to lack of funding and other reasons out there. There is less bed space and a lot more patients. Doing this for 22 years, I've seen ebbs and flows in the system. It just seems to never change. I wish there was one solid answer that would magically fix all of it, but it's a system that's broken. And until we find some remedy on how this can be fixed, we're going to have to keep producing the magic and making it happen. Stay on top of your crisis team, your house supervisor, whoever's in charge of bed control or making the phone calls to assure that that patient is getting to the place that they need to be. Patients who are on extended holds are very unhappy. If they're going to jail, they're even more unhappy. And not only is it a safety issue for them, but it's a safety issue for you. I don't know if you've ever had an issue like this, but I have been in some predicaments where patients not only get agitated and additionally they get angry, but they get violent. I have seen it happen. I've experienced myself, and I pray to God that none of you ever have to go through that. It's just an unfortunate reality that we've gotten used to, and I don't like it. I hate it. And every time we see something happening on the news where there's some kind of violence going on in an emergency department, it crushes my soul. We need to find solutions in all of this. I don't think there's one easy solution. I think this is going to take a lot of effort on a lot of our parts, and this is one of the reasons I've made this channel. I want to keep having discussions to see if there are some ideas that we can't find to try to improve how this happens. 5150, let's just back up a little bit. A 5150 is a hold. In the state of California, it is a 72-hour hold that a physician or an ER physician writes when a patient is expressed that they are a danger to themselves or others, in which they are going to be put on a hold for 72 hours. What you need to remember about 5150s is you are taking away all of the patient's rights. That is all their civil rights. They have been removed and they are under a forced hold. They are not under arrest, but they are legally bound to stay in a medical facility to be evaluated for self-harm or harm of others. It is a very big deal because anytime you take away someone's rights, you're dealing with some legal issues that can get you into hot water if you don't do it correctly. That's why documentation is very important, and hopefully you have an EMR system that helps you with a prodding along and gives you some check boxes that you need to accomplish. If you don't know what they all are, it hopefully guides you. But I've also worked in facilities that have antiquated, outdated EMR systems that don't follow the guidelines of what needs to happen on a medical legal assessment or a medical legal hold. It is up to you to understand what those guidelines are, what the legal ramifications are, and what your duties are as a registered nurse. When they first come in, one of the most important things you need to do is assess the patient, have a discussion, find out if they are at risk for harming themselves or someone else. Sometimes it's coming up with the exact question. Are you thinking of harming yourself? Are you thinking of harming someone else? They tell you what their plan is, that you document it as patient stated, A, B, C, D, this is their plan. This will also help crisis team if they are linked to your EMR system to be able to read the notes, understand what's going on, and it can help facilitate getting them out there sooner or helping get the process moved along quicker. Most importantly, they are safe. Safety is key. If you are dealing with someone who is having thoughts of self-harm, whether it be themselves or someone else, it's important to assess what that is. They say, I'm going to do A, B, and C, document that. But make sure to keep it as detailed as possible because you never know when that information will be needed in the future. It also helps crisis team to better assess what the needs are or what the patient has verbalized to you, and that when they have come in to do their assessment that the story hasn't changed much, because a lot of times if you're a nurse, you know patients change their stories. They tell you one thing, they tell techs another thing, they tell the doctor a whole different thing, usually minimizing whatever tragic thing they've told you. And then when crisis gets there, whether it be an hour to 10, they change their tune. Document whatever you heard. As I sit here doing this video, I'm thinking of all the things I've seen over the many, many years, and I'm just like, there's no one right answer for anything. If anything, it's about communicating with your fellow employees, talking to your doctors, talking to your house supervisors, finding out if there's any resources you can utilize within the hospital to make sure that your patients are kept calm, comfortable, well cared for, monitored, do what you got to do with all the other stuff you got to do. But you know what? Sometimes little interventions can go a long way in reducing your workload. I wish there was more that I could offer you. If they're cold, give them a blanket. If they're hungry, see if you can feed them. If they need medications, see if you can do that. If they are somebody who consumes alcohol, which a lot of people do, talk to the doctors. Make sure you've gotten a good history on that. If they need to have interventions to prevent them from going in withdrawal, make sure you hit that early. Don't wait for them to go into DTs before you're addressing it. Sometimes those early interventions can make for a much more smooth transition as they go about the long haul waiting in your facility. Make sure, though, above all, that you keep them safe, you keep yourself safe. If they need a monitored bed, make sure that they get it as quickly as possible. Drugs and alcohol seem to be the number one reasons patients decompensate when they've self-consumed outside of the ER and then they've come into the ER. It doesn't always happen right away. It can happen over time. Their period of ingestion may have been hours before. It may have been right before they walked in the door. They may be metabolizing it, which can happen that they decompensate within a number of, an hour to number of hours. Just make sure you're watching things. Check the labs as soon as they come up. Intervene before it becomes a problem. Don't ever try to be a hero. If you have a patient that's trying to run out of the emergency department, it is not your job to stop them, regardless if they're on a 5150 or not. That is law enforcement's job. If they want to leave, don't get in their path. You don't need to have two patients instead of one. I wish that I could give you more. Rely on your fellow nurses, rely on your techs, rely on any eyes that you can have to help you while you're there, any hands that you can get to help you while you are there. It's a problem. It's going to continue to be a problem. There are hold times that are increasing throughout the country depending on where you are at. It could be really bad. If you're in a rural ER where the nearest facility where they're going to be transferring to, or even in your own facility, it's going to be a long period of time. The chances are that things are going to get worse while they're in the emergency department, whether it be emotionally, physically, mentally, are pretty high. But, you've got to work with the resources you have within your ability. And sometimes our hands are tied. And that is one of the most frustrating things being an ER nurse. We work with what we have, and sometimes we have very little to work with. Talk to people in your interdisciplinary staff. Talk to your crisis team. See what kind of things that can be done to try to buffer the load that you're taking when it comes to hold patients. If there is a holding unit where house supervisor can get sitters in there, have them do so. Sometimes we have to be a little vocal too, and that's uncomfortable. It's uncomfortable to be vocal with administration, but when patient safety is on the line, sometimes we have to be the voice that speaks for the patients when they can't speak for themselves. Things aren't going to get better overnight. They're not going to get better unless we keep trying to work on things together. I hope that you find a community that you can talk to someone in, whether it be your personal counselor, your clergy, your fellow nurses, finding communities within social media that are safe places where you can talk to other nurses, other doctors, other staff. It's important that you find ways to debrief and come up with ways of making solutions and paving the way for the future. It's a grim outlook at this point in time. I wish it looked better, but it doesn't. I'm here, and I just hope that we can keep the peace, and we're just going to keep coming back and talking about things that are uncomfortable to talk about. I'm confident we'll find solutions, and until then, we're just going to have to keep on pressing on. Peace out.